We're going to talk about adult spinal deformity, so it's a very broad topic, but I'll just cover the high points today. Let me see if my computer wants to work. Hold on. Oh, there we go. Okay, so a little outline background. We'll talk about the background of it, sagittal alignment, or really radiographic parameters, management, osteotomies, and then some brief complications. So a little bit of background of adult spinal deformity surgery. So it's actually pretty common, more common than we think. It occurs at up to about 60% of the older population. Obviously, with our aging population, this is expected to increase. However, only 6% tends to be symptomatic. The average age of those that are seeking care or having symptoms is in their mid-60s. And so adult spinal deformity is different than AIS, or adolescent idiopathic scoliosis, what we talk about as well. Oftentimes, these patients present with pain or radiculopathy or neurogenic claudication. Cosmesis is less of a concern typically with the elderly patient. Their spines tend to be more rigid, unlike AIS patients where they have a pretty mobile spine and correctable spine. They present with poor bone quality, and obviously they have, the older they are, the more concomitant comorbidities they have, so the higher risk of complications. There have been studies looking at the health impact of adult spinal deformity and comparing it to other chronic diseases. And they found that deformity may contribute more debility than chronic disease, including diabetes, heart failure, and lung disease. So it's an issue. It's costly, it's debilitating, and it's painful. And some studies have actually compared it to a quality of life comparable to living with cancer. So definitely not something to ignore. So how has it typically been classified? So there's many different classification schemes that are presented in the literature, and I'll briefly cover one and this one, and then one the Schwab classification. But traditionally, type 1 curves are degenerative curves. Sorry, my arrow's a little off, but this is the most common adult spinal deformity. Although there are many other types that exist, usually degenerative de novo is typically shorter. It's typically a lumbar curve, typically relatively stiff with minimal rotation, and can lead to loss of balance. Here's just a picture of it. So type 2 is idiopathic. These tend to be larger curves. Sorry, that arrow should be a little bit down. Thoracic curves, and the rotation tends to be, tend to have a rotational component at the apex. Type 3 are pathologic curves, lumbosacral scoliosis, and then and metabolic bone disease can also cause type 3 pathologic curves. So that's just a brief classification. More recently, the SRS and Schwab classification system, which describes the deformity in both the coronal and the sagittal planes. However, it puts more emphasis on the sagittal plane because it's been found that there's a substantial effect on patient outcomes with increased global malalignment or increased SVA. And we'll talk a little bit more about that when we talk about radiographic parameters. So when they look at the coronal plane, they have classified it into thoracic, thoracolumbar, lumbar, double curve, and no major coronal deformity. They classify coronal, a major coronal curve if it measures 30 degrees or more. And then they have 3 sagittal modifiers, pelvic incidence minus lumbar lordosis, global alignment, and pelvic tilt. This study looked at 341 patients with ASD who were either treated operatively or non-operatively, and showed that patients who had improvement in the SRS Schwab modifiers, so they had less, they had better global alignment, less pelvic tilt, and their lumbar lordosis was within their pelvic incidence of less than 10. They found that this was associated with improved health-related quality of life measures. This was a multi-center review. So we found that there are different threshold measures that are goals for radiograph or correction for our patients that can be seen radiographically. So we aim for an SVA, or sagittal vertical axis, of less than 5 centimeters, a pelvic tilt of less than 22 degrees, and a PI lumbar lordosis mismatch of less than 10 degrees. So briefly, what's the pathogenesis of deformity or degenerative deformity? So it initially starts with disc degeneration, which leads to abnormal pathologic loading, particularly in the posterior elements, which leads to facet hypertrophy, Ligamentum flavum hypertrophy and instability. This leads to asymmetric disc collapse, and then ultimately your deformity listhesis, wedging of the vertebral of the disc, which leads to de novo deformity. So what are we looking at radiographically? What do we want to get for these patients who come to our clinic with symptoms? We want to get full length or Scoli films, 36-inch cassette films, standing AP lateral radiographs with their hands on their clavicles. We want their knees in extension, so we want them to be in their upright position, and we assess that with their knees in extension, their hips relaxed, and their feet or shoulder width apart, because we want to look at essentially their pelvic tilt or their pelvic compensation, and we'll talk about that when we talk more about these in detail. If they have, we also get an MRI if they're especially if they're having neurogenic claudication or signs of radiculopathy to assess for nerve compression. A CT or CT myelogram may be warranted if they're unable to get an MRI, or obviously if they're or if we need to assess kind of their bone morphology. All right, so briefly, I know we're all familiar with this, but for those who maybe are not, I'll cover it briefly. How do we measure the curve? Most commonly is the Cobb angle. We look at coronal balance here. Again, we look at the essential sacral vertebral line and look at C7 plumb line and determine if it falls to the right or the left. So is the head essentially centered over the pelvis? Sagittal axis or sagittal vertical axis, sagittal balance. We look at, again, the measurement of the mid body of C7 in relation to the posterior superior endpoint, or sorry, posterior superior corner of S1. Obviously, if our head is in front of our pelvis or our sacrum, that's positive. And if we're leaning back or extended, it's a negative SVA. And I'll talk about these. Another measurement that has come to light by Lafarge et al. Is this T1 pelvis angle, or TPA, which was developed in an attempt to establish a single parameter that could take into account spinal alignment and pelvic compensatory mechanisms, whereas the other measurements were only looking at a component of the spine or a component of the pelvis individually. So this takes into account the spinal alignment and then what your pelvis does in order to compensate for that. So it correlates with SVA, pelvic incidence, and lumbar lordosis. Again, it takes into account the pelvic tilt. So one advantage of the TPA angle or measurement is that it can be used without calibration. So, you know, it can be used intraoperatively because we're just measuring an angle, we're not measuring a distance. So we can use this, or we can determine this while the patient's on the table under fluoro. The SRS proposed a target TPA of 10 degrees when doing coronal deformity corrective surgery, and determined that an angle of 20 degrees actually corresponds to severe disability and increased ODI scores, or more disability, more deformity, and the T1 pelvic angle leads to decreased ODI, increased ODI scores or decreased function. Talked about that. So ultimately, the goal is less than 14. Some studies say less than 14. Some studies say less than 10. All right. So there are multiple studies that look at the correlation of radiographic parameters and how these patients do after surgery, with or without surgery, actually. So the number one radiographic measurement that we look at is sagittal balance. So increased sagittal balance leads to more pain, poorer function, decreased health-related quality of life, worse self-image, and then it's been found that the coronal deformity or correction of the coronal deformity is less important. So again, there's multiple studies that look at this, and let me just kind of go through this here. So a study by Glassman et al. This is actually a kind of a staple article. Looks at the impact of positive sagittal balance in adult spinal deformity, and they just found that again, increasing sagittal balance leads to increasing pain and disability. Multiple studies on this, but bottom line is you want to correct the sagittal vertical axis or deformity in the sagittal plane to less than 5 centimeters, and this appears to be the single most important predictor of outcomes. Coronal balance, again, has not been found to correlate with outcomes. The study by Glassman et al. Found that there was a significant coronal imbalance of greater than 4 centimeters was associated with deterioration in pain and function scores, but this was only for patients who were not operated on and who had not had a previous surgery. But they found that patients who were operated on for adult spinal deformity and their coronal imbalance was corrected to within 4 centimeters, that this didn't make an impact on outcomes. So it may not be as important as we think, or maybe we haven't fully assessed this yet. So how do we, or what specifically are we measuring? Again, pelvic incidence. So pelvic incidence is static. This is something that we are born with. This is our normal anatomy. This does not change. The normal range is 48 to 55 degrees. Again, this is fixed. And then the relationship between pelvic tilt and sacral slope is the pelvic incidence equals the pelvic tilt and sacral slope. So, and ultimately this regulates lordosis. So the greater pelvic incidence that somebody has ultimately means your greater sacral slope, and then the more lumbar lordosis you have to have in order to keep your head above your pelvis. And I'll show pictures of that just to help it make sense. But this is the outline. This is how it's measured. So it's measured from the center of the sacral end plate, and then a line drawn through the center of the femoral heads on a lateral radiograph. Sorry, aligned lines. Then there's pelvic tilt. Again, sacral slope plus pelvic tilt equals pelvic incidence. This is the measurement here. It's a line drawn again from the center of the sacral slope, and then to a vertical line drawn from the femoral heads. Normal is about 14 to 18 degrees. Again, we said with deformity correction, we wanted this to be less than 22 degrees. And this is dynamic. So this is something that changes. As you lose lordosis in your lumbar spine, your body, essentially your pelvis, retroverts or tilts backwards in order to maintain your sagittal balance, in order to keep your head above your pelvis. So this is something that we have to assess clinically as well. And this is why we have the patients, when they're taking their lateral radiographs, we have them stand with their knees extended. We want to assess their hips, and if they have got some hip flexion contractures that keeps them from standing upright. This all needs to be taken into account when you're talking about spinal deformity and when you're thinking about correcting their deformity. So sacral slope, again, it's just a measure of the end plate of the sacrum of this S1 and to the horizontal plane. And so this is just a picture here, again, talking about pelvic tilt. So if somebody has a large SVA, so their head is in front of their pelvis, you can see here they're leaning forward, and they have no pelvic tilt, so they have no compensatory mechanism, they're going to walk in a position where their head is in front of their pelvis. That's inefficient. Here, you can see that they have a moderate SVA, so their head is still in front of their pelvis a little bit, but they've got some pelvic tilt or pelvic retroversion, same thing, which helps to compensate for their loss of lordosis, bringing their head back in front or back in line with their sacrum. Again, here you can see that here that the head would be balanced above the pelvis, and they've got a huge pelvic tilt here, or they're tucking in their butt, they're retroverting their pelvis in order to bring their head above. So there's reasons, again, that they're unable to compensate. They've got lumbar stenosis, so they're not able to stand upright because then they develop symptoms, radicular symptoms, pain, neurogenic claudication, or they've got severe hip contractures because of hip arthritis. And this is all something that you want to assess clinically. So again, we can just skip that because I've kind of talked about that. Again, many studies that are looking at sagittal spinal pelvic alignment in adults. And bottom line is we found that lordosis degenerative changes lead to loss of lordosis over time, and this obviously happens as we age. So there are studies that are looking at, actually this is one I kind of already talked about. So this is the Glassman study. Bottom line, it's found that the thoracolumbar and lumbar scores, curves reported lower scores. So the more curve that you have lower down, especially in your lumbar spine, or more kyphosis that you have in your lumbar spine led to inferior outcomes. That's essentially what these graphs are showing. So there has been a more recent change. In 2016, Lafarge et al. Looked at defining spinopelvic alignment thresholds, and this was or is based on age-matched cohorts. So they looked at 773 patients, an average age of 53, both with operative treatment and non-operative treatment, and they established age-ideal radiographic parameters and found that the ideal spinal pelvic values actually increase with age. So meaning the older the patients are, essentially the more their head wants to be slightly in front of their body. They're the increased SVA. So maybe their goals of deformity surgery aren't to aggressively correct the elderly patient, and this is maybe due to to bone quality or neuromuscular habitus, but ultimately the older the patients are, the increased normative values they have the increased values they have of SVA. Younger patients, then they found that require more complete correction, again, while the older patients don't require as aggressive of correction. So how do these patients present to our clinic? Pain is the most common presentation. They can have axial back pain. They can have radicular symptoms. The curve or the fractional curves, they can have stenosis on the concavity, so they have decreased pyramidal height. They can have stretching of the nerves on the convexity of the curve. They can develop neurogenic claudication, so they're coming in, they're saying, I can only walk 5 minutes, I can only stand for 5 minutes, my legs feel heavy, my legs feel weak, I have to stop and then get going. So that's what they'll present with. They have loss of height. They'll say that, I feel like I'm tipping forward. Especially you can ask their spouse. Oftentimes their spouse will notice it before they do. And they often may not be symptomatic. So that's why, we always talk to our patients. Patients will come in and I'm like, well, what's bothering you? And they're like, oh, I have a curve of 30 degrees, this and that. I said, well, no, what's really bothering you? Because not all the time that they've got deformity on radiographs does it correlate with their symptoms. So it's important to talk to your patients and figure out, what's truly bothering them and does it make sense. Cardiopulmonary complications are rare. This typically occurs with large degree curves, typically greater than 90 degrees. Again, cosmesis is typically not an issue with the elderly patients. Look at how they walk, look at how they stand, look at how flexible their curve is, have them lie down on the table to assess for hip flexion contractures, see their hip range of motion. That's very important. A lot of times patients will come in and they have pain, which they think is from their back, but it's actually from their hip. So it's important to do a thorough exam. So what's the natural history of adult spinal deformity? So typically curves that are greater than 30 degrees will progress 1 to 2 degrees per year. For some patients, this can approach 3 degrees per year. It's kind of variable in the literature. It says like 1 to 5. Lumbar curves tend to progress more so than thoracic curves. And then there's additional risk factors that lead that are associated with progression. A rotation of an apical vertebra of 33 degrees or more, lateral isthesis of greater than 6 millimeters, and then an intercrest line of L5. So when L5 is deep seated, it's been found that degenerative lumbar disease progressed faster. And then also, if you've got some rotational isthesis at L3, L4, patients have been found to have increased pain and deformity. Obviously, patients who've got ribs on their pelvis, it's more severe. So management, conservative management, there's, patients will talk about, is there anything else I can do other than surgery? We've recommended physical therapy, injections, massage, chiropractic care, acupuncture. There's many studies that are looking at treatment of symptomatic adult spinal deformity. And pretty much, the bottom line is that they're all adjunctive measures or care but most of the time they're temporary. Their study on the bottom, the costs and benefits of non-operative management, compared non-op to operative patients with lumbar scoliosis and looked at 2-year outcomes, and found that patients that were treated non-operatively had a decline in their health-related quality of life measures. And they also found that this was associated with a cost of approximately $10,000 with patients trying these other conservative measures. So then, at least, well, I can talk about risk factors later, sorry. So then talking about operative treatment. So what are the indications? The indications are to relieve pain and to make patients more functional, to stop the progression of the deformity, and then again, to decrease and hopefully improve their neurologic symptoms. Radiographic goals is to restore spinal alignment and essentially make spinopelvic harmony. Again, we talked about this, SVA less than 5, PI lumbar lordosis mismatch less than 10 degrees, positive or negative, and the pelvic tilt of less than 20. Then ultimately, pelvic incidence plus lumbar lordosis, which is a negative number, and thoracic kyphosis should be less than 45 degrees. We want to achieve solid fusion. We want to decompress. We want to limit reoperations and limit complications. All right, so patient selection is huge in adult spinal deformity. This isn't typically, we're not seeing the patient for the first time and recommending a huge corrective deformity surgery. This is something that you need to talk to your patients about, really understand what their problems are, get the appropriate workup and radiographic studies. You need to talk to them about their weight reduction, because this has been shown to impact complications, especially major complications. And increased BMI is associated with increased complications. You need to enhance their nutrition. Some studies recommend looking at their prealbumin and albumin levels. Preoperative physical therapy is important to increase muscle tone and cardiovascular fitness. And then obviously medical clearance, diabetes, uncontrolled diabetes has been associated with increased risk, smoking cessation, and then a DEXA scan to assess for osteoporosis. Some studies have shown that there is a improved bone quality and decreased risk of proximal junctional kyphosis, which we'll talk about later, with treating patients preoperatively and 6 months postoperatively with teriparatide. And then you need to manage their expectations. So, you need to understand what their expectations are, what their goals are, and do they align with what your goals are of surgery. There's a huge psychological component of this. Some papers will talk about having them meet with a therapist to talk about other underlying mental conditions that may impact their outcomes and ultimately their expectations. So what's the risk benefit of surgery? This is a retrospective review of prospectively collected data. Patients were followed for 2 years. 453 patients, looked at different age groups and outcome measures with patients undergoing deformity correction. Found that risk of developing complications increased with age, increased with comorbidities. And then elderly patients have an increased risk of developing complications, but they have a greater improvement in pain and disability outcome measures than the younger patients. So yes, they have higher risk. Yes, they have more pain, but they also improve greater than other age groups. Again, this just shows that total complications, major and minor, were higher in the elderly patients. The SRS looked at morbidity and mortality of adult scoliosis surgery, looked at about 5,000 cases between 2004 and 2007, and determined that there was an overall complication rate of 13%. Dural tears, implant-related deep infection, superficial, infection were the most commonly reported complications. However, if you look at other studies, it depends on what they're classifying as complication rates. Complication rates in deformity surgery, especially if you're doing osteotomies, can be as high as 80–90%. Most articles will report approximately around 60% complication rate, and that includes like blood transfusions and stuff that may or may not consider a complication. So another study by Glassman, the impact of perioperative complications on clinical outcomes, looked at 138 patients and found that the major complications occurred in approximately 10% of patients. Let me just kind of go over this here. You can look on the right here, the major complications and minor complications. And ultimately, this study looked at, if you had complications during the perioperative time point, does this ultimately impact the long-term or the one-year outcome of how the patients did? And ultimately, they found at 1 year, there was no difference in outcome measures, except in the SF-36 general health, which was slightly lower between groups. So bottom line is, if a patient has a complication during that time, it doesn't necessarily impact the outcome. They all did fairly well and had improvement in their outcomes at 1 year. All right, so talking about operative considerations, there's many flowcharts that can be found in different articles. This kind of, breaks it down. Are they having primarily axial back pain? Radiographically, do they have lateral aesthesis? What's their sagittal imbalance? If they've got a high sagittal imbalance, their head's in front of their pelvis. Ultimately, you would recommend a large fusion. Are they having primary radicular symptoms? Do they have central stenosis or lateral recess stenosis? Is this facet hypertrophy or ligamentum hypertrophy or a disc degenerative problem? If that's the case and they're just having radicular symptoms, you can consider decompression plus or minus limited fusion. We talked about this yesterday in our preoperative conference where there was a patient with a spinal deformity and we were only addressing the fractional curve because their primary symptoms were just L4, L5 radiculopathy. So you have to tailor the treatment to the patient's symptoms and ultimately their overall health. So this study looked at decompression alone versus decompression with limited fusion for the treatment of degenerative lumbar scoliosis in old patients over the age of 65 years. It was in 2012 and looked at patients who had a curve greater than 30 degrees and spinal stenosis. So what they found was 75% of patients who underwent decompression alone, so just the decompression, 75% had recurrence of their symptoms in 5 years, compared with 36% of the patients in the group who underwent decompression with limited fusion. However, 31% of the patients who underwent decompression alone developed recurrence of their symptoms in 6 months. So, that's something to talk about with your patients. So 75% will develop symptoms with just a decompression within 5 years, and 31% of those patients who develop symptoms will actually recur within 6 months. So something to definitely consider. Lanky, Silva, in this article, Adult Degenerative Scoliosis Evaluation and Management, just an overview, developed these treatment levels based on symptoms and radiographic findings. Honestly, this is an article that I've read for many years throughout residency and now and see it talked about. I just don't know how applicable it is or if we use it. So maybe we can talk about this later on down and end of this discussion. But again, if you're looking at level 1 treatment or treatment level 1, you can just see here, it recommends only a decompression. I'll just kind of go through this briefly. Level 2, decompression and fusion. Patients may or may not be having back pain, but their primary symptom is neurogenic claudication or radiculopathy. Level 3, so as you progress, you have more symptoms and more radiographic findings, obviously would warrant more correction and more intervention. Okay, we can go through that. It's not very exciting. So management operation, so again, decompression, limited fusion, and then full fusion. This study by Winter et al. Looked at surgical outcomes of, again, comparing decompression, limited fusion, and then full curve fusion. They found, obviously, with the full fusion, there's higher complication rates. They reported a complication rate of approximately 50%. They had worse improvement in overall pain scores, which is interesting, but they did have higher satisfaction rates than decompression and decompression alone with fusion alone. However, again, they didn't account for spinal pelvic or global balance measures, so I don't know how much we can make of that study. So where do we fuse to? Like what do we determine? How do we determine what levels? What's our upper instrumented vertebra and lower instrumented vertebra? We look at radiographic measurements. We see what vertebrae are bisected by the CSVL. Bottom line is that we do not want to end at a level of instability. So you don't want to end your construct or start your construct at an aesthetic vertebrae. You don't want to end it at a vertebrae that has rotatory subluxation, and then you don't want to start your construct at a kyphotic segment. Again, the proximal extent, it's been talked about in the literature. You want to extend proximally or distal to T9. I'll talk about a study just the next slide about T9, T10. You typically don't want to start your construct at the thoracolumbar junction because of instability in this segment. So bottom line, don't end at kyphosis. So this article here, T9 versus T10 as the upper instrumented vertebrae for correction of adult spinal deformity recommendation. So this study looked at the segmental stability radiographically at each level. And you can see here this graph that there is less movement at T9, T10, T10, 11 radiographically. So they looked at, or ultimately they recommended that the most stable vertebrae to start your construct at was T9, not T10 in this, according to this article, because they said that T10 was only one level above the most, above the mobile segment. So then they said possibly we could recommend fusing to T9. Obviously, you have to take into account a longer surgery, more blood loss. However, some surgeons will say, it's only one more level, but this ultimately does impact the adjacent segments. And then talking about when do we fuse to the sacrum? This by Silva and Lanky, again, Adult Degenerative Scoliosis Evaluation Minute, which is an overview of kind of techniques in deformity surgery. And they recommended that you determine fusion to the sacrum if patients have an oblique takeoff at L5. For fractional curves greater than 15 degrees, you have to include these. If they've got degenerative changes at 5-1, they've got intervertebral disc collapse, they've got spondylolysis at 5-1, if they've had a previous decompression, so any possible chance of instability, or then if you have a longer construct, they recommend fusing to the sacrum. Oh, that's just a picture of a fractional curve in lumbar scoliosis. Other recommendations, considerations, and I know that this is highly debatable in the literature, but some studies will say if you're fusing to the sacrum, you want to consider doing an interbody fusion at 5-1 if you're extending proximally to L3, and then consider iliac screw fixation if extending proximally to L2. And I'm sure we'll have many opinions on that at the end. And then looking at osteotomies, there's multiple studies and overviews of corrective osteotomies. So I'm just going to briefly talk about, what type of osteotomies can we do and do we do. There's the Smith-Peterson osteotomy, or talked about initially with ankylosing spondylitis. It was described as and called the Smith-Peterson osteotomy, but we also refer to these as posterior column osteotomies. There's a pedicle subtraction osteotomy, bone disc bone osteotomy, and then a VCR. And we'll talk about these all briefly. This article here talked about kind of an algorithm based on the deformity type and the type of curve that you have, if it's more smooth or angular, if it's more focal in nature, and it recommends certain types of osteotomies to perform for curve correction. So what are the surgical indications for osteotomies? So again, obviously, if the patient has a rigid deformity, we want to look at lateral and supine radiographs and determine if their curve is flexible, if it corrects with them lying down, or if it's partially flexible. We want to look at, again, the curve acuity. Is it a short angular kyphosis or is it a long kyphosis? That will determine whether we use a PSO versus multiple Smith P osteotomies. And then you want to look at the curve location in relation to the nerves. Is it at the cord level? Is it at cauda equina levels? This ultimately will impact risk factors, length of surgery, and ultimately complications. So there's articles, that look at types of sagittal imbalance. Looking at a type 1 lordotic type 1 deformity, where you don't have where your SVA is within 5 centimeters. Your patients have lumbar hypolordosis, but they're globally balanced. You can consider multiple Smith P osteotomies, so we see this all the time. Type 2 curves, they've got global sagittal imbalance. They've got a rigid deformity. We can consider Smith P's plus interbody versus a pedicle subtraction osteotomy. Again, this is typically used in patients with an SVA of 12 centimeters or more. So they've got significant global imbalance. Looking at coronal balance, this article also talked about, again, you can do asymmetric pedicle subtraction osteotomy depending on where their shoulder's at, what type of curve they have, and how severe it is. So we won't talk about that anymore. There's different grades of osteotomies that we talk about all the time in the operating room. But these grades correspond to the extent of bone resection and increasing degree of destabilizing potential and ability to achieve more correction. So you can see here a posterior column osteotomy is reported that you can get about 5 to 15 degrees. It's more commonly reported around 9 degrees. Pedicle subtraction osteotomy, 25 to 35 degrees, and then a VCR, which is a 3-column resection, you can get full movement, 40 to 60 degrees. Looking at the chart on the right, again, a type 1 is just a partial facetectomy. Type 2 is a complete facetectomy. 3 is a PSO, again, 3-column. 4 is an extended PCO with a disc. 5 is a VCR, and then 6 can be multiple VCRs. So not all osteotomies are created equal. The average, again, correction is approximately 9 degrees for the posterior column osteotomies or Smith P's osteotomies. The correction is ultimately affected by age. Adolescents or patients younger than 21, so an AIS, typically have more motion in their spine. You can get approximately 10 degrees per level, and then older patients, this even decreases as patients above 65. You get less correction with these osteotomies. So again, when do we do Smith-Peterson osteotomies, or how do we do them? We remove the posterior ligaments and the facets, the supraspinous, interspinous, and the ligamentum flavum. In order for these to be effective, you need to have a mobile disc space, because you're shortening the posterior column while extending the anterior column. And again, you get approximately 7 to 10 degrees of correction per level. Here's a picture of it to help it make more sense here, but you can see here we're removing the facets, ligamentum flavum, and the capsule, and then closing down the back side of it with instrumentation. Smith P's can cause excessive posterior closure, so it's we need to assess our foraminal stenosis preoperatively as well as after we close down posteriorly. This article here by Cho et al. Looked at comparison of Smith P's versus pedicle subtraction osteotomy and found that 3 levels of Smith P's is comparable to a correction of 1 pedicle subtraction osteotomy. So this is important to consider, right? I mean, if a surgeon isn't technically skilled or familiar with doing a PSO, you may be able to get away with multiple Smith P osteotomies that can lead to greater correction, less risk, and less blood loss. So pedicle subtraction osteotomy, it's a V-shaped osteotomy, involves the 3 columns. However, you don't lengthen the anterior column, so you don't need to have a mobile disc. You can get greater correction of this. There's a depiction on the right side showing a PSO, and then ultimately closing it down with instrumentation and compression. The ideal candidates for a PSO, again, you've got greater global imbalance, SVA of greater than 12, sharp angular kyphosis, patients with ankylosing spondylitis, so a very stiff spine. You can correct biplanar deformities with a PSO. Patients who have had previous fusions, this is an ideal candidate for, and then patients who are smokers or diabetics and then have poor bone stock. There's bone disc bone osteotomies. I'm actually just going to kind of skip over this because it's kind of, I felt like this was too detailed. But there's just a depiction of a bone disc bone osteotomy. There's different types here that we can see, and I'll kind of go over that. And then vertebral column resection, we do this as well. High risk of this. Some papers will say, you know, there's almost 100% risk of complication when you're doing a VCR. That can be considered including a transfusion. So greatest amount of deformity correction, you can get up to 65 degrees. Indications is, again, it's a rigid multiplanar deformity with global imbalance. You can do a VCR for patients who have congenital malformations, tumors, or spinal apoptosis at L5. There's, again, high neurologic complication rate, and these can definitely be challenging. Typically, a lot of surgeons will not attempt this if they're not familiar with it, or they shouldn't be attempting if they're not familiar with how to do it. Again, just a depiction here, you can see how much motion you can get. You obviously have to stabilize the spine on one side before performing a VCR. And then ultimately the end result at the bottom of the construct or bottom of the page. So just wrapping up here. So what are some complications in more detail of adult spinal deformity corrective surgery? Rod fracture, PJK, and then medical complications. So what is proximal junctional kyphosis? This is defined as an angle measure at the proximal junctional of 10 degrees. So it's a radiographic finding of 10 degrees or more. It typically develops within the first 3 months post-operatively. 65%, 80% within the first 6 months will develop PJK. If they're going to develop it, they develop it early. The incidence is reported in the literature as anywhere from 20 to 40%. And then proximal junctional failure, so PJK, ultimately that leads to symptoms, fracture, instrumentation failure. The revision rates range from 13 to 55% in the literature. Patients have increased rate of symptomatic pain and worse ODI scores if in those patients who develop proximal junctional kyphosis. So what are the predictive factors of proximal junctional kyphosis? Things that are modifiable, things that we can control in the operating room. Disruption of the posterior soft tissue. So this is important. We want to preserve the facet capsules at the proximal levels. We don't want to interrupt the interspinous or supraspinous ligaments, the soft tissue. You don't want to do extensive soft tissue dissection. Anything that disrupts the posterior soft tissues can lead to increased risk of proximal junctional kyphosis. Rigidity of the instrumentation has been shown to lead to PJK. The levels that you instrument, again, we don't want to our upper instrumented level should not be at a kyphotic level or junction. How you approach, they found that a more extensive surgery, anterior and posterior, can lead to a greater risk of PJK. And then the more correction that you obtain, it's also associated with a higher risk of PJK. So, right, if a patient is 15 centimeters positive, their head's in front of their pelvis 15 centimeters, the more correction you aim for, there's a higher risk. The more correction you obtain, there's a higher risk of PJK.
Ina?
Yeah.
Can I stop you there for just 1 second?
Absolutely, I would prefer it.
This, because I don't remember reading this paper. It's been a while.
Yeah.
Of the surgical, they're talking about surgical factors that lead to PJK.
Yes.
And the last one, I certainly, agree with, right? But I'd never seen a paper that was able to quantify
How much?
the disruption of the posterior soft tissues
Mm-hmm.
in a way that they could have a matched cohort or a prospective randomized series or anything that would lead me to believe that there's some modification of my posterior soft tissue technique would change my outcome for proximal junctional kyphosis. I mean, we talk about that all the time. People like to say that, right? Same thing with rigidity. Same thing with choice of levels, right? Right. I just don't know. I mean, is this a paper that kind of waves their hands around that stuff, or does it actually cite real literature that, because sometimes we cite papers that cite papers that don't have real data, and it becomes kind of the dogma, but it's not really based on anything other than expert opinion.
I honestly, you're absolutely right. This is based off of studies, but they are very low quality studies.
Okay.
Yeah.
So, because we've tried everything, right? We've tried cement, we've tried tethers, people have tried hooks, people have tried graduated rods, people have tried flexible members at the upper end of their instrumentation, and yet PJF is more of a problem than PJK. A lot of people get some PJK years down the road, they get degenerative disease above the construct, right? But it's failure. It's the PJF. It's when they have a fracture or a dislocation or a disc herniation, more catastrophic, that is really the issue, right? When people come back myelopathic from spinal cord compression. And I don't know how you would possibly say, oh, I did less disruption of the posterior soft tissue, so I got less of that.
How do you quantify that? Absolutely. And I think that's why it's just dogma that we've learned to accept over time. But I think it's in theory, it makes sense and everybody has just kind of accepted it. But I don't know how we truly quantify what too much is, or if we remove the facet capsule, does that make a difference? Or,
Just want to make sure I'm not missing something. That's all.
Yeah, no. There has not been any groundbreaking studies on this topic, unfortunately. But yeah, just like you alluded to, there's a lot that's been tried. Multiple studies looking at softening the landing zone, changing the rod diameter, screws. This is the most recent study here in 2020. Published in Global Spine Journal. It's a systematic review of the treatment strategies for prevention of PJK. And bottom line is the only therapy that they found that possibly makes a difference on PJF, so failure, needing revision, is perioperative teriparatide, so Forteo treatment, and with for these patients for osteoporosis. They found that cement augmentation, sublaminar tethers, multi-rod constructs have a low evidence for recommendations, and that's including the posterior tension band as well. There's multiple studies on that as well. Some show that it reduces, again, radiographic PJK, but ultimately does not impact proximal junctional failure. So if they're going to fail, they're going to fail. There's really not cement or tethering or multi-constructs that have made a true difference in revision rates.
Yeah, we pulled a really nice piece of Merceline tape out of that lady that we did last week. So I had used Merceline tape on her as a tether, and still came back with failure.
Yeah. So I don't know. I feel like it has to do with just kind of bone quality and so many different factors that I don't think we quite know what to do about that. So again, almost done. Last slide, I think. This here is a prospective multicenter risk factor, looking at risk factors for rod fracture. Bottom line is they found that increased age, increased BMI, and prior spine surgery, and then performing osteotomies leads to increased risk of rod fracture. So in conclusion, deformity is common, can be significantly debilitating. Consider non-operative measures, which may or may not work. They may buy some time, but ultimately if the patient is symptomatic, they do have improvement with surgery. Although you have to consider the risks of surgery and talk to that about the patients. You need to optimize these patients. You need to remember the sagittal and radiographic parameters, and then not all patients are the same. So determine what type of surgery to do. All right, that's all.
Nina, that was great.
Nina.
Comprehensive.
Nina,
well organized.
Thanks.
I'm very disappointed.
Why?
Because I'm
he wanted to give that
exhausted
talk.
right now.
Because what?
Because he wanted to give that talk. He likes it so much. He wants to
Exactly.
take credit.
I'm exhausted. You've successfully exhausted me.
Oh, I'm sorry.
Spectacular. I mean, this is probably one of the most comprehensive talks that we've had on this. So very well done.
It was my talk that I gave actually in residency, and I kind of just adjusted it a little bit.
Wow. Wow, what a whirlwind. Really, really great job. A couple things, a couple thoughts. I think a lot of people that come in with adult spinal deformity that may be in their early 60s, right, that have significant pain, they've already been through the non-operative. And you glanced over, but you brought up a really great paper regarding timing of surgery, the cost of non-operative management, and does age matter, right? We know age is the single most important factor in predicting complications, right? And, sooner is better than later. I think at the end of the day, sooner is better than later because older people have more complex deformities. Older people, we don't, we have to undercorrect them. Older people have osteoporosis. Older people have more medical complications. Although they still have good outcomes, there's a greater, they don't have that ceiling effect that younger people will have with reaching better, health-related quality of outcomes measures. So I think there's something to recommending surgery to patients, understanding those factors. I think you mentioned that. The second thing that Gail brought up, which is a really valid point, and you sort of essentially said, I'm not quite sure what we can do to prevent PJK or PJF, whatever, however you want to look at it. It's probably a host of a lot of things, as you alluded to. But there is some data about soft tissue, preservation, and you had it in your talk. You just never mentioned it. It's the Cal Kabesh paper that you had.
Mm-hmm.
You had a picture of the slide, and what Cal did, and we actually popularized this, but Cal took it to the next level and studied it. He did a match cohort looking at doing MIS fixation at the top of the construct, theoretically preservation, it's voodoo, preservation of soft tissue structures, and passing the rod members up through the screw extensions and having a softer landing up there.
Mm-hmm.
And it showed that it had a treatment effect in reducing compared to a matched cohort of people that did not have that quote unquote soft tissue preservation. So it was a small data point, right? It wasn't, I think it was about 20 or 25 patients comparatively. I can't remember exactly, but that there is very small amount of evidence to suggest that soft tissue preservation plays a role. We also know that PJK occurs in kids, right?
Mm-hmm.
And in kids, they have good bone theoretically. They have good soft tissue theoretically. They're good healers theoretically, right? So, and those MIS techniques as well have been shown, or soft tissue preservation techniques have been shown to be helpful in kids, which is a completely different animal. And then lastly, neurologic risks, significant. You glanced over that just a little bit, but they're much more significant than, a lot of the SRS large database studies. There's a bunch of other studies that will suggest that neurologic risks with adult spinal deformity, especially with osteotomies, can approach 25+%. Mm-hmm. So that's not something that you want to gloss over when you're talking to your patients. Most of the complications, as you alluded to, are correctable, and we can get them through. There is a significant but smaller amount that are, that are not correctable, and people have, long-term sequelae. So I think it's just patient counseling. This is a big problem, as our baby boomers are aging. So we're all going to see these patients throughout the course of our practice. I still think the biggest challenge for me in these cases is deciding how small versus how big you go. right? The smaller the case, right, you have to weigh that with lower morbidity, but less durability in my mind. The larger the case, you have to weigh that with higher complication rate, right? But longer durability potentially, right? So that's the balancing act that you have. And then the last comment I would make is, you didn't, you talked a lot about shortening procedures for osteotomies. Rarely do you have to do big osteotomies for primary de novo scoliosis, as you know. Those are for rigid revision. Those are typically the cases we're doing osteotomies. But there is the entity, and there's a large faction of people out there that are doing indirect decompression, lateral-based approaches, anterior column lengthening, posterior column shortening procedures for the correction. So just you see that a little bit. I know Kavanaugh is a big advocate of that, as you guys know. But just to keep that in mind as well. But once again, spectacular job. You successfully exhausted me.
Yeah, I was going to add on to, I was going to make a similar point to what Dr. Ludwig just said, in the sense that ultimately when you're trying to create lordosis, you can either lengthen the anterior portion of the spine or shorten the posterior portion of the spine. And to a great extent, we like to work posteriorly, and it's kind of familiar territory to us. And even a PSO is kind of a procedure that we can get ourselves through, but the tolerance of the neural elements for shortening is finite, right? So especially in the cord area, you can't shorten at a single segment more than about 1 centimeter, or else the spinal cord won't tolerate that. Even in the lumbar spine, if you do too much correction, too much posterior shortening, the dural sac will buckle. And you can end up with a complete myelographic block related to over-shortening in the lumbar spine. And sometimes people have even talked about doing duroplasties to shorten the dura to avoid that complication. So the advantage of a VCR is that because you totally release the front, because you take out the whole vertebra, you can lengthen the front at the same time that you shorten the back. And likewise, doing anterior column, although I don't think the data on laterals is great in the sense that I'm not sure they really correct sagittal balance very well. The concept of releasing the front, lengthening it, and shortening the back simultaneously is a good one. Theoretically, it depends how you get there, because it avoids excessive shortening, which can lead to a lot of neurologic complications. So that's one of the reasons why we often do A-lifts at the distal lumbar spine if there are open segments there, because it allows us to gain some anterior column length. And I think that's just an important thing to keep in mind when you're planning out your surgical corrections. The other thing you should understand, and you breezed over this, Nina, when you were talking about the extended PSOs, the disc bone as you call them, disc bone osteotomies, I think, but some form of extended PSO. One of the problems with PSOs is that there's a pretty high, you wouldn't guess it because you're going bone on bone in the front, but there's a pretty high pseudarthrosis rate through the posterior fusion mass, which leads to rod fracture down the road because you don't actually heal. And that happens when you do a PSO, but the disc above or the disc below is not fused. And it probably has to do with the fact that you don't completely close the PSO in the back. You make it too big. So one of the advantages of doing a disc bone extended PSO osteotomy is that you at least get rid of one of those disc spaces. So now you're going to get bony healing through the entire segment, and you avoid the pseudarthrosis rate that's been problematic with PSOs. So just be aware that PSO pseudarthrosis is a real problem, and it's a technical issue when you do your osteotomies and how you close them.
What about, how much how, maybe I just haven't paid attention to it, but are we treating patients with teriparatide? And if so, like, when do you start it? When do you stop it?
In general, we're not, because the insurance companies won't pay for it, right? The indications, the on-label indications for Forteo are pretty restrictive, and it's hard to get insurance approval. So then patients have to pay out of pocket. And so there's a woman who does an osteoporosis clinic up at St. Joe's, Mare. I'm trying to remember what her last name is. And I sent people up to her, not uncommonly, to kind of have a consultation. And more often than not, there's either a medical contraindication to it, or it won't be approved by insurance. How long to treat is, I think the data is kind of mixed. It's not great. Again, it seems like 6 months. They treat for a year or two if they're treating osteoporosis. But in order to get the surgical effect of decreased failure rate of instrumentation and decreased fracture rate junctionally, I think it's about 6 months.
Okay.
Steve, do you know any?
It's 6 months, but it's like the obligatory 6 months, right? There's no hard data to support that. There's some studies, and Sam Cho, I think, did the study. You may have even brought it up, but there's a 6-month study. There's a 9-month study that I've heard about. At the end of the day, insurance companies will not pay for it unless your T-score is less than negative 4.0. So it's tough, right? You're seeing somebody in clinic and they have a T-score of 3, and they have they need a huge adult spinal deformity procedure, and you know that they're osteoporotic, but you also know that and they're maybe 65, 66 years old, but you also know that you're not going to be able to pay for a very expensive modality unless they can afford it out of pocket. And it's allegedly like $10,000. It's something egregious.
Oh, wow.
Yeah, it's very expensive. So it's a challenge. So we don't take control over that, but that's the challenge. It's the approval of at that negative 4.0 that you're gonna need to contend with. So Nita, great job. It's 8:06. I think we recorded this, so this will live on in infamy.